you for giving some time, and most importantly, I thank the organizers for an opportunity to share with you what we have been, or basically how we contour at Johns Hopkins, and reflecting sort of the things that I've learned over the years, and including most recently my time that continues at Johns Hopkins that continues to influence how I think about contouring. When I started using traditional sort of 2D techniques that you see in this top right hand corner, and we caused a lot of side effects. We certainly didn't miss the cancer, but the reason why I think I continue to teach myself and to evolve in how I contour head and neck cancer patients is because this is the foundation for how we reduce normal tissue injury. We can get all the cancer, as you can see with the old technique, but what we really want to accomplish for our patients is to not only get rid of the cancer, but more importantly, to reduce side effects. And head and neck contouring and the continued learning and evolution of head and neck contouring is this foundation. And we all know that IMRT, which is the foundation for conformal radiotherapy techniques, has allowed us to reduce the severity and the risk of late dry mouth or xerostomia. And in another forum, we have data to show that there are stem cells in the parotid gland, and that this is important, and that we can further optimize on this. But this slide is to show you that by knowing how to contour and not treat too much of the parotid gland, we can certainly reduce some xerostomia. But there's a lot more. And I would not have imagined, as you can see in this slide, that's some examples of patients I've treated at Johns Hopkins with cancers around the eye. I would not ever have imagined when I started learning conformal radiotherapy that I could do things like this. Like I can irradiate around and behind the eye, I can irradiate within the eye, and even in this case here on the far right, we can even create now a ring of dosimetry so that it reduces the dose on the optic nerve. And what we can also do is this. We can actually now, with refinements in how we contour, we can even do partial larynx radiation. And what you see here, just as an example, this is a left supraglottic area epiglottic cancer right here. And because we know from our surgeons that there are normal barriers to spread of the cancer, we can partially radiate this, no different than some of the surgeons can partially operate on this. And so you can see that the lines of mucositis line up with the dosimetry. And so the real question is, how can we get there? How can we continue to evolve how we contour, whether or not it's in the definitive setting or in the post-op setting? And in fact, I think actually post-op contouring adds another layer of complexity beyond sort of definitive planning. And these are the foundations for what I teach our residents, is the principles. And there's one tip. And so what it comes down to is a growing continual medical education about head and neck anatomy, because I see head and neck anatomy as the roadmap for me to be able to sit down and draw a head and neck case and have confidence in being able to limit where I draw to treat the cancer, and other areas where, with some degree of confidence, I can make the radiation lower to reduce the side effects. And the first principle is, and I want to introduce you to, is a concept that we've come to term at Hopkins called stacking the volumes. And it's because photon radiation, most of the dose is actually through secondary ionized radiation, because most of our cells are water. And so as a result, just like when you have an electron field, we all know that we have to have a certain size for the electron field for there to be electronic or electron equilibrium within your field. Similarly, in 3 dimensions, As you can see in the picture to the right, if I had one slice like this, and I drew it like this, and I drew another slice like this above, the problem is that where my palms overlap, there is going to be electron scatter and equilibrium. But if it's large enough, where my fingers are, there will be less overlap or no overlap. And as a result, the algorithm is going to try to drive those here and here, especially if these are large, and that creates a lot of dosimetric hotspots. And it creates it more difficult to be able to get the conformality that we want in reducing toxicities. And so this principle of stacking does require some understanding of how the anatomy changes from slice to slice to slice. And in some ways, it's made easier by taking one set of volume from one slice and copying it down a couple of slices or even one slice, although that adds a lot of time. And it comes down to your slice thickness. And then these slices, these contours will be overlapping and then making the anatomic modifications on one slice and then proceeding down that way. And it's a lot easier if you make volumes that are simple and curvilinear. And this is where I would say I jump right down to the bottom in terms of a tip. We all contour with mouse like this typically. The challenge with the mouse is that the point of rotation and when we're moving is largely elbow and wrist. And that's the reason why it can be very uncomfortable. And if it's possible, one of the things that we have learned over the years. Hello? Oh, okay. Is to consider something like a stylus. Now, I realize that it may not be available everywhere, but this allows you then to reduce the strain on your wrist and your arm, especially as I learned from Emily that some of you are contouring up to 10 cases a week, and that can be very hazardous. And so the idea is to ensure that your beams are fundamentally stacked on top of each other. And just like in the 2D area, when I was learning, we were taught to find beam angles that would see most of our target and not say see our spinal cord. That's the same idea that I try to draw now in terms of my volumes, especially for the neck. And as a result, when we do this, we're able to then add what we call avoidance structures to then really create sharp dosimetric gradients to be able to accomplish normal tissue sparing in ways that I would not have thought possible. And so this graphic is just to show you that just like a complicated roadmap, the anatomy in the head and neck is incredibly complicated, but it does tell us how cancer can spread and how cancer may not spread, and gives us the confidence to be able to draw our volumes in ways that we can then ensure that we're treating the cancer, but then making the radiation lower in other areas. And so the first is actually the cervical neck. And I realize this is post-op, and you've already had a lecture on the cervical neck. I would say that the only that why I bring this up is because this is the most common example is the lymphatic anatomy, and without even thinking, we take advantage of the fact that the lymphatics are contiguous with each other, and as a result, we are able to make decisions about where to contour, because if we have cancer in the jugular digastric or level 2 area, we know that the next nodal level area of concern is level 3, for instance. And we have an anatomic landmarks that I think have been well established with various atlases and are being taught that allows us to recognize these landmarks for us to be able to draw our cervical neck. And this is a great example of where anatomy is actually helping us be able to draw. And as we grow and we learn the anatomy, we start to be able to see more of the various grays to help us really understand what may be involved and what may not be. And that's this lower panel, so that we start to add the ability to see that that this muscle here is, which is the posterior belly, the digastric, is really the upper limit of level 2, which is what the surgeons use. And And so as a result, this gives us the ability to see this as a landmark, especially when the neck is in a different position where the normal bony landmarks may not be as accurate, for instance. And so this is how I've continued to be able to add to our ability to make decisions by continuing to learn the anatomy. And as for the primary site, it is complicated. It does require you to understand that cancers can spread along the mucosa, and it can spread deeper in terms of the submucosa and muscle, and it requires you to understand how the muscles, especially in the tongue, can all move in certain directions that tend to cause cancers to spread in certain directions more than others. And understanding, obviously, that cartilage and bone can prevent cancers from spreading. And as a result, this helps us be able to draw rational volumes, both in the definitive setting and in the post-op setting. I realize that many will use PET, for instance, and I think that that can be incredibly helpful. And we like to use it, especially for the cervical neck, when we are looking for lymph nodes that may or may not be palpable. And that's an incredibly helpful situation. But I would caution you that in the throat is only about 4 centimeters wide. And so if you actually fuse a PET scan, particularly pre-op, you're going to possibly get parts of the tumor that's grown into the throat pre-op that may not be there already in the post-op setting because of the surgery. And as a result, you can result in unnecessary radiation especially in the larynx. And so this is what I'm talking about in terms of these exophytic tumors that sort of fall into the larynx. And you have to have that ability to discern that in the post-operative setting. And clearly being able to see the cancer before the surgery and understand how it was growing, and so that you can better use all the imaging tools to be able to rationally draw your target volume is very helpful. Post-operatively, as I said, there are some challenges because of the nature of the surgery. And so talking to the surgeon, I think many have already mentioned that, is very helpful. And being able to talk their language and anatomy is just as important to be able to then for you to be able to put together the extent of the cancer in the post-operative setting. And I would encourage you to look at the full report. And oftentimes it can be very confusing, but the way the specimens are processed can give you an idea of how the surgery was done and where the tumor may be spreading. And obviously, one of the downsides with surgery is that the way the wound is open and exposed poses the risk of tumor seeding. So when a surgeon does make an incision in the neck, that wound, when it's closed, does run the risk of tumor seeding, not only in the scar, but also in the areas where the tissues were open. And regardless of how well they may have irrigated the wound to be able to reduce the risk, it would still be important for you to cover all those areas. And so before I continue, I'm going to, after those early remarks, I'm going to just pose to the group here a case that's 45-year-old who's had surgery, very much like a fellow of mine's that actually I'm treating right now. He has a mandibular alveolar cancer that has gone into the bone. He's got several nodes, as you can see, in levels 1 and 2 as expected, but no extracapsular extension. Margins are clear, but there is evidence of PNI. What adjuvant treatment would you recommend?
Okay, so I will start the simple question. You should see it on the screen. And Dr. Quon, you can see the results as they come in. We see mostly C and D.
Okay.
So we'll wait
Oh,
for
we're getting some A now. We're getting some A.
uh-huh. So we will start seeing more participants. 38, 40% of the participants have answered. I'm going to wait until we have a bit of the half of the participants. If you don't see the simple questions, you can also type your answer on the screen. So
this is wonderful. It's like a horse race here.
yes. So I think most of the participants have answered. Oh,
63, 4. Oh,
yeah.
this is wonderful. This is a
Yes.
lot of fun to see this.
I will end the simple question right now. Most of our participants have answered.
Okay.
I think you can see the results on the screen.
Okay. Wonderful. Can we see the results?
Yes. So
Okay.
most of the participants, 54% answered C, chemo and radiation therapy until for 66 gray.
Yeah. Yeah.
After
Absolutely.
that, answer D with 28 participants, answer B, 11 participants, and answer A was only 8 participants.
Okay. All right. So I want you to keep this in mind. And this is actually, I got to say that technically, based upon probably the best data, many would probably favor D. However, the challenge is that the way the chemotherapy has emerged, largely for positive margins and extracapsular extension, I think that there is certainly some who would say no chemotherapy, but simply because of the T4 nature. And I think that that's the reason why I really like this question, that many would have said, well, let's give chemotherapy or increase the radiation dose. We know, and I'm going to go over we know from the MD Anderson data, which is really what drives most of the radiotherapy dose recommendation, that higher doses beyond sort of in their trial 57.6 or 63 actually for what they call high risk, which was ECE and positive margin, did not lead to increased outcome. But I actually also, I do wonder in the back of my mind sometimes when I'm dealing with a T4 tumor that's gone into the bone, whether or not that might actually be beneficial. But the evidence, unfortunately, doesn't really support this, particularly for the high risk, because when they did their trial, they did include tumors that were potentially T4, and I'll show you in the next slide. But the idea was that they took patients that were post-op, and based upon a scoring system that reflected what had been known at that time in terms of relative factors, although it was a bit arbitrary, they were able to put patients into a lower risk group or higher risk group. And as you can see, the higher risk group was randomized to a higher dose of 68.4. And I'm just going to give the secret away, and many of you know, the results did not show any benefit. And the reason being is that the thinking is that in the higher cohort, that higher dose that you think would be beneficial was being offset by the increased treatment time because the radiation was being delivered in 1.8 gray per fraction. And that led to a subsequent accelerated post-operative radiation trial. I'm going to show you in a few slides here. But this is the stratification scheme. And as you can see, you had T4s that actually gave you 4 points. And then you would have, for instance, multiple nodes that would give you 2 points, but you had essentially negative margins, which is 1 point. It's we don't intuitively think like this, but the concept here is that the pathology and the compilation of pathology does interact in a way that probably influence the 66 gray, I wouldn't say is necessarily wrong. I actually think that there's, as I said, there's a part of me that wonders about that because of the T4 nature. But it seems to be offset in some situations when there are higher pathology that accelerated or the total treatment time may be just as important. And therefore, what you may be doing is by adding more dose, you may actually be extending the treatment time. And so it's how you're adding that extra dose as well too. And so these were the initial results that were reported by Lester Peters. And in fact, actually in the lower risk group, some of you may remember, they actually had 54 gray, and they found that there was an increased local relapse And that's the reason why 57.6 was changed. And now in modern practice, we basically have rounded this up to 60 gray. And so many have favored, particularly for higher risk, 63 gray without the benefit of higher doses for the reasons I've just already mentioned. In their early results, it was interesting. ECE was not necessarily considered a high risk factor. In fact, the lymph node of 6 centimeters or more was. And so what you could then do is see what is the influence of dose on ECE. And as you can see, that 57.6 looked to be inferior to higher doses of 63. And with long-term follow-up, David Rosenthal presented this. And in fact, you can see that there's probably not surprisingly as much difference with ECE, even though they did recommend a higher dose of 63 gray for ECE. And some of this, again, as I mentioned before, is probably the influence of total treatment time and how you're actually giving the radiotherapy. And so for this reason, it's not surprising that in the multivariate analysis, total package time, or TPT, was very important, as you can see. And interestingly, when they actually analyzed for local regional control, their negative margins also included those situations where the surgeon went back and revised the margin, or where the cancer was not necessarily at the mucosal cut edge, which was their definition of a negative margin, but was close, that is within 5 millimeters of the cut edge here. And that's an important point to remember, because many of us do worry that when we actually have tumors close to the edge, that this could be construed close to be a positive margin. But it's interesting that this was not the case. And I'm going to show you also that seems to be the same case for the use of chemotherapy in post-operative radiation. And so, as I mentioned, the thinking was that 68 gray did not lead to any benefit because maybe it was being offset by accelerated tumor repopulation. And so Dr. Ang and the MD Anderson group did do an additional study, and this is the study that followed, where they took patients with higher risk pathology. This time they defined high risk pathology as ECE or multiple pathologic risk factors, and they randomized them. They randomized them to either giving the 63 gray in 5 weeks by giving twice-a-day radiation in the last couple of weeks of treatment, using what they called then the delayed concomitant boost, versus the standard 7 weeks. And as you can see, although the p-value was negative, was basically negative, this is probably one of what we call a classic underpowered study, because the curves do flatten out here, and it clearly shows the benefit of being able to treat in a much more accelerated manner that reduces the total treatment time and therefore improves your results, and may not therefore need that extra dose of radiation on top of that, as appealing as it is. It's interesting that I want to make this point, that in the low risk group, this is the first time they did a study where patients were just watched. So they trusted the surgery. And there was not an insignificant, but it was low, it was about 10%. And that's what I sort of tell my patients. It's interesting that the intermediate risk group that got 57.6 also.
¿No puedes no estar discutiendo?
I'm sorry? Is there a question?
I don't think so. Sorry, just a little bit of background noise.
No worries. Okay. Yeah. So the intermediate risk group actually seemed to do just as well as the low risk group. To me, suggesting that that's 57.6, 60 gray may be beneficial. We know we use chemotherapy, and we all base it upon the sort of the summary analysis by Jacques Bernier, where positive margins in ECE. This is where the EORTC did use larger stage tumors as one of the criteria, including T4. And so it's really not clear how that benefit of chemotherapy is in that scenario. And certainly this has become accepted as sort of the standard indications for post-operative treatment for head and neck cancer. But it's helpful to remember that at that time, when these two trials were being done, it wasn't the the definition of what a positive margin was not as rigorous as has emerged in the last 10 years, whereby we're actually having our pathologists measure the distance of the tumor to the edge of the specimen that's being reported. And in fact, you have to go back in the discussion section in Dr. Cooper's paper, and this is Dr. Bernier's paper. Essentially, what I've highlighted here, and you can take a look at it afterwards, is that the way they described it in the discussion, it implies that the positive margin was tumor really at that cut edge here, not necessarily say within 5 millimeters as the reason for them to use concurrent chemotherapy. And this is important because now we're in the era of transoral surgery, especially for oral pharynx cancers. And now the trials, including our ECOG 3311, has started to put numbers to the specimen edge that adds to decisions about adjuvant therapy. And I provided a summary of comparison of ECOG 3311 and the PATHOS trial, which is an ongoing randomized phase 3 trial that's being done in Europe that is randomizing patients to either 50 gray or 60 gray, as you can see in the comment, or with or without chemotherapy, which is actually really beneficial, which we could not do in 3311. And so these are the trials that I think are going to add to our post-operative decisions regarding HPV post-operative management. And it's because these results seem to be very good. And it'll be very interesting to see what PATHOS shows, particularly for some of these tumors with multiple lymph nodes in the neck and a small primary, which is the typical HPV patient. So I'm going to interrupt this with another question here. Which of the following is the most important factor in determining outcome for a patient with a T4 N2B lower, sort of like the one before, mandibular alveolus cancer? A, B, C, or D?
Okay, so right now the participants should see the simple question in their screen. So we will wait until a few answers come back. And while the answers come back, Dr. Quon, I have a question for you. Because I think that you touched something that was very critical for the session, and is the close or negative margins definition. And I would like to know, what is your definition currently?
Yeah, so at Hopkins, we use basically tumor right at the edge margin. We don't necessarily use that safety margin.
Okay.
Yeah. But I will say that even amongst our medical oncologists, in terms of the use of chemotherapy, they do worry when they say there's a 2 millimeter margin. Remember, that 2 millimeter margin oftentimes reflects a specimen that was elastic. And so when they cut it, the tumor may have been further away, and so it shrinks a little bit. And then there's a little bit further shrinking because of the fixation of the specimen. And so that's the challenge sometimes in still using a distance as your cutoff for a positive margin. I think that the way we also do this at Hopkins is we have a conversation with the surgeons because they have additional information. And I think many in the audience here understand this, that there are those that are clearly clear margins because when the surgeon was cutting, the tumor was, say, just pushing and growing, and they felt really comfortable in the way they cut and removed the tumor. Or there are tumors that were sticking or very infiltrative into the tissues, and the surgeon did not have a good, comfortable feeling as they were resecting, or they had difficulty in resecting it. There, I think the difference, if you had 2 millimeter cancer from the 2 millimeters from your specimen edge, that would be very different. And I think that we would be, just like many, treating the second situation as a positive margin in terms of radiotherapy dose and also the use of concurrent chemotherapy. So I see the pose in. This is a lot of fun to see this. And so, I mean, a lot of these things are very, very important. But I think the overall treatment time is the one thing I was trying to impress in the last 10 slides in the little section there to help you understand that in one of the most important things that we can do in post-operative care is really ensuring the timely delivery all of the adjuvant therapy from beginning to end, beginning from surgery to the end of radiation. And that's not just the time for after surgery, but also thinking about how you can fractionate and prescribe your radiotherapy dose in a way that actually can accelerate it a little bit. And there's a variety of different things that I think many now have come to appreciate in terms of multiple treatments per day, for instance, or the use of a simultaneous in-field boost, which is actually the approach that I personally take and that many of my colleagues at Hopkins take as well too. So with that in mind, I'm going to move on to this. We're going to start contouring together. There's a couple of slides I want to show you. When we draw, knowing the anatomy is really important. And so what I like to teach our residents is when you draw, think of you actually making an incision. And so you want to know where you are actually putting that radiotherapy dose. And this is actually a case that I found, that a patient I took over in follow-up. This patient had a tonsil cancer and it was post-operative. And while a decision was made to treat both sides of the neck, and that can be debated, and it can be debated about how much of the neck superiorly, including the retropharyngeal and skull base area. The question is, to me, that when I saw this, oh, sorry, I'm using the wrong screen. The question that you can see here is this green line is 54 gray. And this, knowing the anatomy, knowing that this is the muscles of the floor of the mouth, but this is the back of the tongue here, and that these are the muscles that make up the neck here, and this is the post-operative neck, I have no problems with this kind of volume being drawn here. I think that that's very reasonable, especially if you are concerned that it may be going into the tongue and you want to include that and therefore include a neck volume. But one of the things that I think we have to start to question is this green line that goes right across not only all the tongue base, but also the mucosa of the pharynx here. And that's the kind of volume that I want you to start thinking about. And many would say that it's because of the potential for intervening lymphatics. Well, there certainly was a concern, and Dr. Halstead, when he started at Hopkins, raised that concern with breast cancer. And there were many surgeons, including Dr. Krill, who continued that concept in head and neck. And so when they operated, they cut everything out. But now our surgeons are not necessarily cutting everything out to remove the cancer. And I think we have to ask ourselves, are we really needing to do this? And does that justify the side effects that would occur when you are giving an increased volume like this? And so this is the kind of case that I want this audience to start thinking about when you are practicing, because one of the concepts that we've introduced is being confident that you don't need this green line here. This is post-op, and so this tonsil cancer that was here is not sticking out anymore. What you have is basically, if I put a camera into here, what you basically have is a wound here that is healing and contracting. And therefore, you have the confidence to be able to not just draw a green line, but also the confidence to be able to draw a structure that I'm going to introduce in the next few slides of what we call an avoidance structure to push the radiation away. And when you do this after a tonsil cancer, and this is a case that I treated when I was at Penn, this is a right-sided tonsil cancer. And you can see that the uvula has been changed because of surgery. But what you can see in these slides here, this is the mucositis on the right side, right to the middle right here on the bottom left panel on C. But then this redness, this hyperemia from the radiation, it stops right here. This matches up with this avoidance structure. And then you can see on this side here, nothing. And the way I like to do this is when I see a patient post-op, and post-op gives you that confidence that you already know more information than you would definitively of where the cancer extended. And then I can be more confident in making this area lower in radiation. The key is translating this is what we see when we see the patient in the clinic to where it is on your CT. And that is the key. Being able to say, this needs to be treated, and this corresponds to this area that I saw, and knowing that this area here, this is the upper soft palate, which is several slices above, also does not need to be treated because the surgery was mainly on the lower part here. These are the things that I think one has to add to your education in your practice as a continuing education, as you look and see. But in the post-operative setting, especially in the tonsil case, you don't have to treat right across the pharynx like I showed you in the other case. Here's another example, and I'm being a little whimsical using circle therapy. But this is actually a case that was drawn by a resident just before I came to Hopkins, and I took over this patient's care. I got to know this patient because he's a taxi cab driver, and I commute down from Philadelphia down to Baltimore, and he would often see me at the train station, and we'd get to know each other. And I got to know how he and his wife were trying to make ends meet, but they were really trying to start a family, and so he got to tell me these stories. And unfortunately, he was treated for a tongue cancer. I'm going to show you the slide in a moment, the pathology in a moment. Next slide. It basically was a T1 tongue cancer on the right side. And what he was treated was with a circle here to treat the tongue. This was treating the neck. And when they did the expansion on this circle, it went down into the larynx here. And as you can see, this is now down into the larynx right here. This is epiglottis, and here you can see the hyoid bone. This red represents a symmetric expansion on a right-sided post-operative tongue cancer. And you can see on the right side, right here, it goes, this dose, although they tried to reduce the dose, because they were giving radiation on both sides of the neck, there was a lot of dose that crept into the middle of the throat here in the larynx, including down on the esophagus. And I want you to remember that, because I'm going to show you what his throat looks like 8 years later, because one of the things we do is, as we follow patients, we have the ability to scope and record our exams. And I want to show you some of these images here. This is original pathology. He was a T1 oral tongue on the right side. Perineural spread for sure. You need radiation. Clear margins, 1.5 centimeters. His neck dissection was negative. Unfortunately, with this large volume, he was given concurrent chemotherapy for some reason. And as a result, and this is an important point here, I want you to bear this in mind. One of the things I think we don't appreciate is that post-operative or definitive, when we cause mucositis in the throat, especially if it's circumferential, and when the patient has so much side effects that they can't manage through, what happens is you form synechia because the inflamed tissue, just like the inflamed tissue on skin tends to stick, you tend to form these scar bands. And what happens is that when we eat, we kind of break it up. But what would be even better would be if we had one side with mucositis and the other side with no mucositis. And I'm making a case to use these avoidance structures so that then the patient can swallow, and you're less likely to get that circumferential synechia. And you can see here, this is 2012, 2017, and this was 2018, 7 years later, not 8 years later. What he has had was progressive fibrosis of the synechia that went from his pharynx down into his larynx. And unfortunately, so much so to the point that he couldn't eat anymore, and he had to have a total removal of the larynx and his pharynx. And as a result, he couldn't work as a cabbie as a cab driver because he couldn't talk anymore. So his life was totally changed. And to me, this case stands out in my mind, not only because I got to know this fella personally, but it reminds me of how narrow the throat is and how important it is that when we draw our volumes, it can have very long-term impact on our patients and in their lives as well. This, by comparison, when I teach our residents, and I'm mindful of time, is a similar case where we use these avoidance structures, and he was similar to a T1 tongue cancer that you can see now 6 years later, his larynx looks nice and normal. Okay, so I'm going to jump right to here. When I draw these volumes, I draw a PTV, not a CTV. But it's okay to draw a CTV and then expand. But what you need to do is when you expand, you have to realize that if you do a symmetric expansion, dose can go into the larynx, and it's important for you to go back and cut off of that. We cut off of the skin because we use the body contour to just easily do that. But don't forget, you have to crop off the larynx, or else you're going to get a lot of dose right here that really affects the swallow. I tend to draw I draw a lot of OAR, including the parotid and submandibular glands, which are really the functional glands, but I make use of these avoidance structures, and I want to show you what these are right now. So I'm gonna poll the audience here. Dr. Ornelas, I'm sorry, I'm just looking at my screen. Or anyone give me an answer here. Let's do this. What structure am I pointing to right here? Sorry.
So right now we would like to ask the participants to answer participant.
Yeah.
I don't know if someone wants to raise their hand or open their mic, or you can either type on your chat if you don't feel good.
Yeah, thank you. I'm sorry?
Yes, so for the participants, what structure are you seeing on the screen that Dr. Quon is pointing to? You can either, if someone wants to open their mic, they're welcome. So the answers are coming in. So we have the buccinerator muscle in the chat.
Okay.
Someone is saying, it's a prosthesis, the buccinerator, buccal cheek.
Yep.
So a few answers on the chat, Dr. Quon.
Yeah, absolutely. And in fact, it is the buccal mucosa. And
Oh,
this is the mouthpiece that we put in the mouth, and this is the tongue. It's important to understand that this is buccal mucosa. When you look in the patient's mouth, you then start to see it merge with the mucosa on the tonsil. And this part here is your tonsil. This is your soft palate right here in uvula. And as a result, and this is therefore the muscle that is deep to the mucosa right here. And this muscle you can't see, it's in the buccal tissue. And in fact, this is called the masseter muscle. The point being is that for tonsil cancer, if I want to treat the tonsil fossa, I need to identify where this is and realize that this is tongue right here. This is not tonsil, and it's separate. And so as a result, when I start to draw in the next few slides here, like here, where I want to say, draw my tonsil volume, I'm going to, and you can see how this area here is a little thicker than this side here. If I want to treat the tonsil, all that I'm doing is just like a neck volume, where you would then, on this side, let's take the neck volume, this is the SCM here, you would draw a volume like this, where you use the muscle of the SCM, and you would come up to the throat or the pharynx, tonsil, and you would come back and draw like that. The post-operative tonsil is just like the neck volume, and I like to build on that. All that you're doing is just adding a little bit of margin, and you're drawing back like this here. These tonsil cancers can actually go deeper, and if there was evidence of trismus or deeper invasion, you might want to draw it a little bit more medial or lateral to include all the medial pterygoid. But certainly splitting the muscle like this would be entirely reasonable to think of a PTV like that. Okay, so I'm going to go down to the next slide here. if we were to continue to draw, is there someone who wants to draw the next slice for what we call a low-dose PTV that would include the neck and the tonsil? Or do you want to draw two separate PTVs? Okay, is there anyone who wants to draw on the screen for me?
So we asked the participants to participate. You can see if you're on your Zoom, there is this option to annotate on the screen if someone wants to draw the volume for Dr. Quon. Okay, great. I see some of the participants. Dr.
Wonderful.
Quon, are you seeing the content?
Yeah, wonderful. Yeah. Okay.
This is awesome.
All right. Yes. So exactly. And so I completely agree. That's this idea that you don't need to draw right across. So even if I was to draw, I'm going to draw now on here. I'm going to make mine's I will make it still that blue so that you can see that Hopkins blue. So again, if I was to draw the neck, I'm not going to draw something like this. Okay. You don't want to draw that like that. In fact, that is exactly what I was trying to show you before, where you can cause unnecessary radiation across the tonsil. And if you were to look in the mouth, you would wonder why that was being done. So what you want to do is here, this is the SCM.
I'm going to erase the participants.
For sure. Yeah.
And for us to see yours, okay?
Yeah, absolutely.
Okay.
If I was to do bilateral neck, this is the SCM right here. Right here. And I use the medial pterygoid as a landmark. And then I come up and I follow the direction of the pharynx. And then I come back and I close. I like to draw, as I said before, simple curved linear lines. And then on this side here, I know that this is the buccal tissue and it follows to my tonsil right here. And this is tongue right here. And I know, therefore, if I want to treat a low tongue and a little bit of the soft palate, I can go into just about here. And I would draw something like that. So the difference between my post-op tonsil and my neck is that this volume is going in a little bit more into the pharynx, but it doesn't have to be all the way in here unless the pathology said, hey, my cancer went into the tongue a lot. Or you actually had a tongue cancer. And so that's reason why, as an example, to me as a template, drawing a post-operative tonsil is one step in addition to how I would draw a neck. And then a post-operative, sure, you can control. A tongue would be then going further into the tongue, like tongue base like that. So these are the concepts that I'm trying to help you sort of see that you don't need to draw everything across. What you want to do is understand this anatomy, that this area here is separate from this area, and therefore draw your PTVs accordingly. So
Dr. Quon,
yes,
there's a question in the chat that I think is relevant. Is
yeah,
this only for T1 or T2 tumors? Because I don't know, but for instance, I feel like for the tongue cancer that you show, we're usually taught that it's super aggressive and that your volume should be big. I don't know if this happens to other participants, but
yeah.
someone is asking if this is T1 or T2 tumors only.
No, I mean, I think I'm going to show you, and that's the reason why in the other case I have a tongue cancer. It was it was a tongue cancer that went deeper, and you do need to be. And the reason why for tongue cancer, you need to be a little bit more generous. So if this was a tongue cancer, what happens is that here, this area right here, forgive me, let me just erase here. Aggressive does not necessarily mean you have to treat everything. And sometimes you do and I end up having to do, and you have to make these judgment decisions about deciding what areas am I going to treat and what areas can I not treat. And I think that that's probably how I would answer that question. So for instance, if this was the tongue cancer, these muscles are the deeper muscles in the tongue, what we call the extrinsics. And this is a common area where people may miss these tumors. And that's the reason why everyone's taught to go big or go home, right? And so the idea is that oftentimes you can't tell which of these muscle fibers are involved, and that's the concern. And I recognize that. But what you can do in a scenario like that is draw something like this that is basically treating all of, not only, this is back of tongue here. This is the part of the tongue that you can feel, but this part here is insensate. It's in the deeper muscle. So that's what you have to understand, the three-dimensional nature of tongue cancers. And so if you drew something like this, or even if you go to this side here, you can start to spare some of this tissue right here. There's no reason why the contralateral back of the tongue or the pharynx needs to be treated, all depending on the scenario where, say, it was in the middle of the tongue and it went deep into the muscles of the tongue, and including the deeper extrinsic muscles of the tongue. I think that that's how I would respond to that kind of situation. So it's more, these concepts are pertinent even for larger tumors. In fact, by drawing simple large volumes, you do have the challenge of having to decide what areas can I not treat, and that's the key to being able to matriculate and being able to draw volumes that treat what you need to treat, but also minimize the side effects where you can minimize side effects. Does that answer your question?
It does, thank you. And I think
Okay.
it really encourages to be more careful when deciding what to treat or not to treat. Thank you.
So let me just come through here. I'll go through all these slices here, and I'll show you, this is actually what I ended up drawing here. And actually, is the slice before here. This is helpful probably here. And can I play this? So here's the video here. This is me going through all the slices here. I'm just going to jump here to, this was just to let you see what the rest of the neck looked like. And about 41 here is where I start to come down here. And here I started up here. This is the soft palate here. And so I don't need to go into a lot of the tongue here. And as I come down more inferiorly, this line will go more past the pharynx and grow into the tongue right here. Okay. This tells me I'm at the floor of mouth. The downside with oftentimes planning these patients post-op is I have a lot of surgical changes, and I know the cancer was right here. And even though the tongue looks swollen, I have to make a judgment and say, this is probably just normal tissue that was just swollen because of the surgery. And so that's what I've done here. I draw this out, and just like you've been taught, or the neck, you draw to the platysma, but in the post-op situation here, I do draw the volumes closer to the surgical wound underneath here, so that I accept the increased skin toxicity. And as I come down lower here, this is no different than definitive treatment. Now this is the muscle, and I'm using the muscle and some of the subcutaneous fat so that I don't get unnecessary skin toxicity here. I come back and I use the scalene muscles as my landmark, but I realize that if I use the carotid, as I come down lower, I would then end up treating more of the chest wall. This is now the next dose level. So that was my low dose level. And as I said, I used a simultaneous infield boost. So this is now 200. So this is that equivalent of 57.6. And this is getting that post-operative dose where everything was operated on. And then there were several nodes that I felt, because of the size of the node, with a little bit of judgment, I brought it up to 63 gray, and I'm going to show you that. And I used 2.1 as my way to accelerate, to reduce the treatment time. And so that's how I treated this patient here. Okay, so we're just going to jump right to there. And so this is me now coming down and drawing the 63 gray volume in 2.1. And you should start to see it very soon in the neck nodes here, right here. Okay, and that's that's how I drew this. And this is probably the next most important slide here, or video. This is my avoidance structure. And so this is where I tell the algorithm to control the dose. I use a D50 or mean dose of 3000 centigrade. And that I have found to be very, very helpful to reduce mucositis here. And it also seems to reduce long-term complications. I use the PTV as my template because just like my PTV can change slice to slice, what happens is to know so that I don't have an avoidance structure that gets in the way of dosing on my PTV, I put a rind. I use 5 millimeters, but it's not just 5 millimeters. You have to think about the slice thickness. If your slice thickness is 3 millimeters and you use a rind of 2 millimeters, you're not going to be able to see where on one slice your PTV sticks out, and therefore you don't want to draw an avoidance structure a slice above and then not to have electron contribution here. And so this video here helps you to see that I use this blue line right here. That's my 5 millimeter expansion. Sorry. And I draw avoidance structures to keep the radiation low, not just in the larynx, but also in the back part here in what we call the upper esophageal sphincter, which is the part where we gulp, where we swallow. And that's the most important part to minimize so that we don't cause any long-term swallowing problems and aspiration pneumonia. Okay. All right. So here's the next case. I think we're getting close to the hour, but I think we can get this case in. This was a tongue cancer. So it was a T2, but it was 8 millimeter depth of invasion. This is the neck dissection. 1 out of 18 nodes. Any suggestions on how we would treat this patient or in terms of post-operative treatment?
So if any participants want to write or to tell us how you would treat this patient, feel free to open your mic and participate with Dr. Quon.
So I see a couple folks. I might just forgive me if I'm picking on anyone. I'm gonna click on this. I have a Carla Paco. How would you treat?
So Dr. Quon, yes, Carla is asking if, yes, Carla, you can give the dose. How would you treat it?
Yeah.
¿Cómo lo tratarías?
And would you treat one side of the neck or both sides of the neck?
Okay.
Yeah.
Yes, I think I could treat both sides of the neck, and I could include level 1 to 5 levels of the left side of the neck.
Okay.
And in the right side, I think since level 1 to level 4.
Okay.
And the doses for the left side, I think it could be penetrate to level 1 until level 4. I think we could give 66 rays.
Okay. And so can I ask you, would you give chemotherapy or no chemotherapy?
I think in this case it's necessary to give chemotherapy because of the depth of the invasion and because there is perineural invasion too.
Okay. So you're worried about the additional perineural spread and the depth of invasion as the concern.
Yes.
Okay. Okay. You know,
and in the lecho of a glossectomy, I think we could give 60 grays to the, I don't know how to say in English, lecho quirúrgico.
Yeah. So
tumor bed.
Tumor bed, yes, for
Tumor
sure.
bed, yes.
Yeah,
Yes.
I mean, I think the surgery accomplished good negative margins around there. The real challenge is does the depth of invasion and the perineural spread in this situation, because it's a tongue cancer, add to that greater risk of then needing to add chemotherapy and the higher dose. And as I said before, I share with the concerns because we've all had these tongue cancers that behave outside of what we would expect. You know, it's interesting that the studies that I've shown you would all seem to point to probably just post-operative radiation alone without the chemotherapy, but there certainly is a school of thought, I agree with you, that the bigger and deeper tumors might benefit from chemotherapy, but it's probably not something that some would do. And so I think that you bring up some really good points, and I understand where you're coming from. Let me show you what we did in terms of the volume, okay? So this is, again, just scrolling down the neck. I'm just going to jump right to it here. So this is where we started drawing. So this is my low-dose PTV. This is my 5400, actually, my elective radiation to the opposite side. But I was drawing here. I noticed these lymph nodes here. And to jump to it, there's we in this video, we actually went back. This is going up now. And the reason why I went higher is because when we went back and we looked at the PET scan, these lymph nodes were there before the surgery. And so this brings up a challenge sometimes in the post-operative treatment, that you might actually have gross tumor that, or findings that raise the concern of actually certain cancer that has not been surgically treated or might be cancer, and this happens quite often, and that's the reason why I wanted to show this case. And so because of those lymph nodes and because they were present on PET scan, we went ahead and did bilateral neck, and I took it up to the retropharyngeal area here. Then, so that was my 54 gray. This is now my 60 gray. Again, I'm not drawing it right across the throat here, and I'm going to stop right here because this is the surgery bed here. This is the floor of mouth. So the side of the tongue would be roughly about here. And we had seen the patient, and her tongue cancer was right here. 8 millimeters. Yeah, it could be towards midline. And certainly there are surgical clips here, and this is in the extrinsic part of the muscle. But I decided that, just like you discussed, Maria, this is the back of the tongue, and this is the pharynx right here. And so it requires a little bit of judgment for sure. And this is the reason why medicine is human, and this is why we're all different. I chose not to swing it all the way around at this point here because this is where I want her to be able to swallow and put food here. Later on, once I get past this area where these are sensate mucosa, I do start to bring it together, and I'll show that. And this is the 60 gray here, right here, right there. I start to bring it together because this is now then that submandibular area that I want to treat in continuity.
Dr. Quon, there was a question that I think we can do right now.
Yep.
How long does it take for you to do or start the adjuvant treatment? Do you have like a time frame to do it?
Yeah.
Is there like a time frame that you consider relevant to do it?
Yeah, I mean, I think many would say that 6 weeks is the answer that everyone uses, but here's how we actually do it here. You can't really do anything for the first 2 weeks. Patients are swollen, and the contour is going to change. So usually by the 3rd week after the surgery, when we know that we have to have had post-operative treatment because the pathology would be available within the first 1 to 2 weeks. So once I know that, we schedule the sim. We're about week 3 after surgery, maybe close to 4 sometimes. And then we plan, and we take the several weeks that we need to, and then we start usually by post-op week 6. If it's a little bit in 7, I'm okay, because using the simultaneous infield boost I am essentially accelerating the radiation a little bit, particularly in areas where I have a bit of a higher risk or concern. So I use that 2.1 to give me my 63, for instance. So actually, for many of those who actually, like Carla, when you said 66, I don't disagree. When I use 2.1 for my 63, I'm sort of closer to biologically like 65 gray. Okay.
Yes.
So yeah, I completely agree with you there. But
Okay.
but here's a scenario here. We got those nodes there, and we often have to be in the situation. Do we actually stop planning or go back to surgery, or do we even try to biopsy these and then delay things, or do we try to treat these definitively? And I think that those are the scenarios that we often face. And so in this scenario, we chose, because these lymph nodes were small, they were very difficult to potentially identify and biopsy by ultrasound. What we chose to do was to go ahead and treat, because these PETs on imaging, this is with my resident, we're going through, they seem very convincing and similar to the opposite side here, including the opposite side. So, and because they were small in area, we would decide to bring up the dose in this area here. And that's actually what so the way I'm doing this is I'm using 54, 60, and then the 63 to these areas. And then I have a cone down to that area to bring up the dose to the 70 gray. So again, these volumes here, I take advantage that there's air gap here. I don't draw it right to the lips. This is my boost area of those lymph nodes. And then after I've drawn all this, I will add my 5mm expansion, and then I will draw structures to push the radiation away from what parts of the pharynx I've chosen, Maria, even in a case like this where that is deeply that's 8mm. And I'm treating to the other side. I'm going to draw a structure right here to keep the dose low so that it makes some parts easier for patients to manipulate food, to be able to swallow, and then to particularly not only protect the larynx, but also the back part of the larynx, which is where we swallow and gulp, and so that we don't cause acute dysphagia and long-term dysphagia. Okay, and this is the avoidance structure right here. I got the 5mm. I'm protecting the lips too, right here. Here I'm protecting the soft palate, right here. And I'm coming down the pharynx right here. This is the back of the tongue right here.
What mean dose do you use for this avoidance structure? Do you use the normal constraints or a mean dose for this avoidance?
Oh, I think I mentioned what this has been empiric over the years. I have found, so I use two constraints. I allow the dose that needs to come right up against this structure here. So if I'm putting 63 gray here, right? It does not make sense for me to have a constraint that is, I use a max dose, but it's really more of a median of 30 gray that I want. I'm willing to allow the dose to fall off on this, and oftentimes within 5mm, most doses can drop off about 500 sonogray. So if I'm giving 63 gray here, I expect that this is going to be in the high 50s. So I'm not going to use a maximum constraint right here on these avoidance structures here that is higher than say 57 or 58. I'm not going to use I want a max dose of 65 gray and because that's going to create conflict here. I want to give the radiation right here. I want the radiation to fall and then to really fall aggressively right here to start to push this down so that I'm trying to achieve a mean dose of D50 of less than 3,000. It does get hard. There's no doubt about that when you have both sides and when it's small.
two participants in the chat, and I think this is something that's new for me, at least, this avoidance structure.
Yep.
But there are some worry about, do you ever get like marginal recurrences? And there was a participant that say, at first, I tried to be very strict with my contouring, and then I started seeing more recurrences, mostly when the tumor was in the base of the tongue. Could you share with us your experience with these
Sure.
marginal recurrences?
So actually, one of the things we do at Hopkins, and Emily is familiar, we actually have a database, and we this is Mosaic, but we record whether or not recurrences occur and whether or not they're marginal or not, actually. And we also recur toxicities, including patient-reported outcome measures. And this is an example of this patient here. Our iPad system was down this past Thursday. Yes, that's right. But this was last week, and you can see this patient, very little pain, normal swallow. We use SSQ, which is a validated measure. We know the normal is up to 0 to 250 her skin, and this is her, what we call salivary flow. And so to this kind of environment, we record each time when we see patients as to whether or not there is recurrence or not. I think the way I would answer that question that was being posed, I understand the concern. I think that it comes down to each individual person sitting down and making decisions clearly about what needs to be treated and what can be spared. And that's a judgment decision. That comes down to understanding where these tumors are, understanding the anatomy, and being able to see in each individual situation whether or not there may actually have been tumor closer to the back of the tongue, for instance. So I can't comment. I have not seen more recurrences, say, because tumors are in the back of the tongue, for instance. I think this is where each person, as we mature in our careers, as we treat patients, we use every patient as a case example for us to learn more anatomy and to be able to distinguish cancer from not. And that's what we call experience. But I can tell you that in our experience, we've not had this increased recurrence rate. And in the post-op setting, it should be less so because you've already had more information that defines the extent of the tumor. When muscles are infiltrated by tumor, that's a scenario where you probably do need to be a little bit more generous with your margins and where you're treating. But in the first case scenario, like in the post-operative tonsil where it's been removed transorally, you don't have a lot of that concern, for sure. Those are two ends of the spectrum that are very different. And so the volume that you draw in your CTB, PTB would be very different, and it reflects the level of risk.
Thank you.
Yeah. So I think we've done this one here. So lastly, this slide was put in here by Dr. Kim, and I completely agree with this, actually. And I think the reason why I left this in here was because the surface dose is much higher, and we don't need to put bolus with IMRT. When we treat across this area here, most of our techniques is circumferential, like this. And so we are having beams that are tangentially coming across the neck. That brings up the dose right here. When you put bolus on, the downside with bolus is you increase the skin toxicity even more. That's desquamation. And that's another reason for patients to stop their treatment. I also noticed that I tended to get a lot more skin complications, atrophy, and cosmetic changes when I did use bolus around the stoma in my early career. And so I similarly agree, I've stopped that. Yeah. If there's tumor that you can actually see, yeah, I would put bolus there. Okay. Maria, I know we're short on time, but I'm open to any more questions. I'm really at the end of my slides here.
Okay, that's great. Yes, we have like 5 more minutes for questions, and there are a few questions on the chat. And I think
Perfect.
I'm going to use this opportunity because you talked about the bolus, and there was someone that asked if you ever include the scar. And I think that you, for the tracheostomy, I think we are clear that you don't use a bolus.
Yeah.
But if you ever, do you ever include the surgical scar?
I did when we did 2D before, because 50% of the dose is coming across. And in order to get the dose close to the skin, because there is a risk of seeding, I did before. IMRT, same thing. You're tangential across there, and maybe I wasn't clear in some of the videos. I draw my PTV right up to the skin at the level of the scar. So I delineate the scar with a wire.
Mm-hmm.
And as I'm going down the neck volume, I'm drawing my volume closer to the skin in those areas there.
Yes, you did have an example, and I noticed the wires. So
Yeah.
I think that's why one of the participants had
Yeah.
the
No,
question.
it's a really good question. I'm glad the participant asked, because I would not put a bolus unless I actually see cancer there. But I
Okay.
do draw my target volume close right up to the skin in that area. Remember, if you draw up against the skin in a large area, you're going to cause a lot of skin desquamation, and you have the same problems again. And so because the wound is open, you can see the changes underneath the platysma coming up to the skin. So you draw your neck volume coming up to the skin, and then you take advantage of the fat that's in all of us underneath the skin and between the platysma and the skin, so that I reduce the dose to the skin toxicity.
Okay, great.
Yeah,
Thank
that's a
you
good
for
question.
having that question.
Yeah.
So, yes, there was another question about hypofractionation. Do
Mhm.
you ever use it? And this was mostly related to the time frame we established, because we
Yeah.
say hopefully first 7 weeks post-op to be starting. So the participant was asking, okay, so if I'm at week, I don't know, 10, would you use hypofractionation? And my question is, would you use hypo or hyperfractionation?
Yeah, I think the overall what we've learned is that time and getting the dose intensity in there is important. I mean, and there's a variety of different ways. You can use altered fractionation, or we call it accelerated, by giving twice a day treatment. That's one way. But the hypofractionation question, I'm basically hypofractionating when I'm using simultaneous info boost. So when I go, my low dose is 1.8 to 30 gray. I mean, 30 fractions to 54 gray, right? And that's my elective dosing if I need to dose areas that I worry about cancer that wasn't necessarily manipulated by surgery and operated on, like the opposite neck. Like I agree with Carla in that tongue case we did. I would treat to the opposite side, but I would treat to 54 gray or some in the 50s. That's what we call our low dose PTV. And then that equivalent of the MD Anderson 57.6, I think many of us basically use 60 gray now, and that's 2 gray per fraction. So, and 30 fractions. And then the area that's more of a concern, in order to shorten the time, I use 2.1 to 63. And I've even used 2.15, which takes me closer to the mid 60s for a positive margin.
Okay.
Okay. And there, that is essentially, that simultaneous info boost essentially is hypofractionation. But I am not, because of the volume that I'm treating here, I am not treating like at 5, 6 gray per fraction. Remember, there's an inverse relationship between the dose per fraction and the volume that you're treating, which is basically why SBRT is limited to smaller areas. We're not treating big areas because then you would necrose tissue.
Oh, thank you. So I think that I think I wrote it in the chat for the participants, the doses that you're using and would recommend. So, and I don't know if we have 1 more minute, Emily, or should we wrap up, and otherwise we can share the questions with you, Dr. Quon.
I think we
I'm
are.
here.
One more minute if the interpreter doesn't mind. One more question.
Sure.
Okay, we will. So I will go with this first questions because you showed it in a case. Do you usually use a tongue depressor devices
Yeah.
in each case in the
Yeah.
post-op setting and any device to reduce oral toxicity?
Yeah, it is a really good question. So when your target is the tongue, I actually don't use anything, or I'm fearful of using something because my experience has been that when you put something in the mouth, the tongue moves more. And so that's the problem. However, there are some situations when you can get away with it because what you're trying to do, say you're treating a tongue cancer, when you're using an oral stent, what you're doing is you're trying to move the hard palate and a little bit of the soft palate superiorly so that they don't get the unnecessary mucositis in that scenario. And similarly for sinonasal cases, like here, skull-based cases, you're treating here, but the floor of the nose is the roof of your mouth. And your tongue, with the mouth closed, sits right up against the roof of your mouth. And so depressing the tongue helps. So in that second situation, I always use a mouthpiece. Now, the problem is not all mouthpieces are the same. Ideally, in that second situation, what you really want is something that pushes the tongue down, but not back. And some of that is patient-based. So what happens is when you put it in their mouth, you have to teach patients to not push it back, or else you're going to push the tongue back into the field. And what we do is we actually, when we want to push the tongue down, but we are concerned about patients not breathing through the nose, I actually take straws and I actually wrap it in dental wax. And when the dental wax hardens, it actually is somewhat rigid. It's not completely reproducible all the time. We are actually going to be 3D printing mouthpieces that allow air channels so that so it's rigid. But I realize that not everyone has that. And honestly, the use of 3D printing is just really starting, and it's something that I've been working on for the last 6 months. But what you can do is take some straws, and if you have dental wax, soften it and wrap it around. And then when it firms up, then you can place it in the mouth. But make sure before you put it in a patient's mouth, when you're making it, that you drain any water that may be in the straws, because the last thing you want to do is put it in the mouth and this hot water goes down the throat. Okay?